Yeah, I think it is starting. Okay. We can see your screen now. I think we're fine.
Okay, wait, but I have to, I need to share just part of the screen.
I
I'd
think
like to know where to get it.
I think you can use the full screen button.
Wait, wait, check it out.
Okay, let me shortly introduce you while you fix this. Today I'm so thrilled. Yes, I think it's fixed now. Today I'm so thrilled to have my mentor and the one who taught me everything I know in the surgeries and in the research and everything. Dr. Hani has been my mentor since 2011. We met actually 2 months after the revolution in 2011, in April 2011. And this was a life changing event for me. This guy you are going to speak to today and listen to today taught me everything I know, and I owe him a lot. I'm so grateful we have you today, and I'm so looking forward for the presentation. Also, I'm so proud to be part of this research team and part of this work that you are going to present today. And I will not talk much. I will just let you start your presentation. Thank you, Doctor, for being with us.
Um, Dear Nada, thank you for your kind words and thank you for allowing me to present our work to your audience and to allow us to present and be able to give something to the young dentist. So to keep it short, we'll start, but I think I have a problem with my sharing. Wait,
Yes,
it's,
I think it's working fine.
yes, okay. Okay, today we'll be speaking about immediate implants. I've given this lecture like 2 weeks ago, 10 days ago. Maybe some of you heard it and maybe not, but this time you'll get the chance to stop me within the lecture if you want to, if this is your policy. I don't mind.
Yes, it is.
Uh, because with the ITI, these were more advanced or more seasoned dentists. So you didn't have a chance to ask. Maybe today, if you have any question within the lecture, you could just raise your hand and we'll stop and discuss the topic. We'll
Okay.
go slowly, not as fast as last time. So we'll have a chance to apprehend most of the things that we are going through. Okay, if we're talking about immediate implants, we all wish, if we get a case like this, to extract a tooth, place an implant, and place the implant immediately, have enough buccal bone, have nice keratinized thick tissues, and if possible, place a temporary abutment and place even a crown. So the patient would go out from the clinic having a tooth and being extremely satisfied. But actually, not all our cases are this. We'll be talking about immediate implants in thick versus thick buccal bone in the aesthetic zone. That's a topic which we have been working for like almost 2 years now. We're nearly halfway through with the cases. We're waiting for the follow-ups. We have placed most of the implants, and we'll see what will happen. Okay, immediate implants is now part of modern dentistry. It's not a new or novel technique. It has established itself as a part of implantology, and it's here to stay. Its survival rates, its success, satisfaction, how it works in our hands as clinicians, it's definitely gonna expand. It's not going away at all the literature are in favor of using immediate implants if you can.
Mhm.
So if we're going to talk about the parameters of that influence treatment planning, First of all, the buccal bone plate integrity. If the buccal bone is there and how thick it is. So first of all, we have to see if we have any deficiencies like dehiscence or fenestrations. That's the first point. And the second point is thickness. And that's the point we're gonna debate today. If the buccal plate is not intact, the current recommendation is not to place an implant. Although, like Egyptian group just published a paper by Absam Askari, I think most of you read it. They placed an implant with a non-intact buccal bone and placed a membrane, and they used a paracrystal approach to place bone graft. We'll see how it will go, but I think it's kind of a nice technique.
I think we are taking immediate too far.
بجد؟ The second thing, with second option, which is very important, the remaining apical bone. We have to have apical bone remaining or apical to the implant in order to achieve some primary stability. So we don't use a thick or a wide diameter implant to get your retention from the neighboring bone. Actually, you aim to get the main primary stability from the apical 3 to 5 bone, and as we'll discuss later, the palatal bone.
Mm-hmm.
We have to anticipate the dimension of the jumping gap because we'll learn that the jumping gap is very important. I always say when I started placing implants, there was these Frilet 2 implants. There was huge implants which were like graduated. They were like having steps on them, and they had the aim to fill the gap in order to be placed just inside the socket, filling the whole socket, touching the whole bone buccal lingual medial distally, and then ended up in disasters. So having a jumping gap, placing an implant that advocates or having a jumping gap on the buccal side, it's a good thing. It's not a bad thing at all. That's a jumping gap. It's a distance between the implant and the buccal bone. It has a horizontal size and a more apical side. Dimension of the socket. The dimension of the socket will dictate the size of the implant that you're gonna place. So if you're gonna place a bigger implant, you'll have less of a gap. If you're gonna go for a narrower implant, you'll have a bigger gap. So we will learn that if you have the choice between two implants, you should go for the smaller one, so the narrow one. The bigger one does not give you any advantage. Mechanically, the narrow ones, I'm not talking about 3.3, I'm talking about 3.7, which are now considered to be the normal or the norm in implant dentistry. So using rather a narrow one will give you more advantages and will be easy to work with them than having thicker implants. The root orientation, that's a tricky part because if you had a look at the literature, Gluckman had this nice classification of implants in immediate teeth. And he classified the root orientation into several classifications and advocated that the most advantages will be gained from type 1, 2, and 2A and 2B. 2B, that's a little bit thin, and we shouldn't go there, or we should. That will be our topic today. Other than that, it will be difficult to place the implant. So before placing the implant, look at the orientation, because some orientations, especially if the patient has a vertical maxillary excess and the patient has the root orientation is unfavorable, maybe you should wait and go for a delayed approach.
I think we'll be having a diagram addressing this root orientation issue.
We have one? No, I don't think we have one. It's we don't have one. We'll be talking today about the buccal bone integrity and thickness and the dimension of the jumping gap. These are the two items that we'll be addressing today.
But the bottom line of the last slide, doctor, is that not all cases will be indicated for immediate because, nowadays people just extract and put implants without considering all these parameters.
Some guidelines now, and we'll discover that the current guidelines, which are a little bit strict, just allow us to place the implant in 5% of the cases. So if you're gonna adhere to the strict or so the most academic guidelines, you should be placing like 5 implants out of 100 cases that you extract into anterior zone, which is not the case. I know many of my friends and dentists, they place like at least 70 to 80% of the cases they extract, they place implants in them, which could work in most of the cases, but the cases which fail, which will fail miserably. So it's a kind of a risky business. So if you're gonna place an immediate implant, you should go for atraumatic extraction. Atraumatic extraction, we could use peritomes, use piezotomes, use whatever you want. Use your Benix system, use your gold forceps, use your whatever you want, as long as you go for an atraumatic extraction. Multi-rooted teeth should be separated. You should go for rotation. You should defer from any buccolingual motions. That's a basic atraumatic extraction procedure. Another thing is the flapless procedures. We stopped doing any flaps now. You do not raise the flap when placing an immediate implant. In the old days, we needed to see the bone. Now we know when seeing the bone, there is a cost. You lose at least 0.5 millimeters of bone when you strip your bone from its periosteum, from its nourishment. So don't do that. It's good to see the bone, but you'll pay the price. In order to achieve a good stability from the little bone which is found apical and palatal to the alveolar process or the alveolus, we go a little bit, we do for an undersized osteotomy preparation, meaning already our implants or our implant system advocate undersized preparation. That means the drill, which is actually intended for a 3.75 implant, is actually a 3.4 has a 3.4 diameter. So already we're going for undersized drilling in the everyday practice. If we have hard bone, in order to compensate for that, we use a bone tap in order to get a slightly larger osteotomy in hard bone. In case of immediate implants, especially in the maxilla where you can get really soft bone, sometimes we do not stop at we do not use the final drill, it's the 3.4 to place a 3.7 implant. No, we go a little bit even further, a more radical approach. We could drill the 2.3 implant, 3.2 drill, and place a 3.7 implant. So we could skip one whole drill. Sometimes if the bone is a little bit hard, you could go halfway through with the final drill, but not the whole way through. These tips and tricks you'll learn with time, and with experience, you'll know when to go for the last drill and when not. And even with ample experience, you'll end up having some duds and some bad cases where implants will not achieve primary stability. Subcrestal approach. If you're gonna place your implants, you have to place your implants subcrestally. First of all, you have to know your implant system. Does it allow me to place it subcrestally? If yes, I could go a little bit more subcrestally. But even if the system was the polished color, they should be placed 1 or 2 millimeters subcrestally. Why? Because I know you'll lose at least 1 or 2 millimeters of the crestal bone. So you have to compensate for the expected bone loss. You have to go subcrestally. You measure from the buccal bone, you'll go 1 millimeter below. If you're using a system that allows you to go deeper, go deeper. Going deeper will give you a little bit advantage of a better buccal bone, give you more advantage at having a better emergence profile, give you like a space where you can give a better emergence profile for your case. If you're gonna place your implant, you have to place your implant as palatal as possible. You should engage the palatal wall. You should not place your implant in the mid of your osteotomy, of your alveolus. Go more palatal, that you'll have more engagement palatally, you'll have more bone to implant contact palatally, you'll get better stability, and you'll have a gap buccally, which is all benefits that you can gain.
Doctor, if I may interrupt here about the subcrestal placement of the implant. Um, the question remains how much subcrestally? Because sometimes when we have crestal bone resorption already, so maybe this resorption does not allow us to place the implant immediately. So we need to know the range, the maximum range from the gingival margin to the implant platform.
Okay, first of all, you have to know your implant system, because there are certain implant systems that allow or that not allow. It's recommended to place your implant 2 millimeters subcrestally, even in your delayed implant systems, when you delayed implant placement. So, for instance, if you're using, I prefer to use some Ankylus. If you're using Neodent, GM or CM, if you're using Bicon, if you're using what else?
Most
What?
Mostly the Morse cone connections.
They all allow us to go a little bit deeper, or not a little bit, like up to 2 millimeters deeper. So you have the advantage of going a little bit deeper without compromising aesthetics or compromising the functionality of your implant. Because bone could and will build on top of your implant surface. Unlike other implants with polished colors, for instance, like Zimmer, like Implant Direct, you won't have that. The bone will go till the first thread. So you're gonna, if you go a little bit deeper, you just lose more bone. So in my opinion, if you're gonna go for immediate implants, choose an implant system that allows you to go a little bit deeper. But if you're gonna be like very strict, if you're gonna, I never use, and for instance, a Zimmer and an immediate implant. That would be, I mean, this would be foolish to do that. So I always go at least 1 millimeter from the bony crest, and I don't choose cases with massive buccal bone resorption. So if they're just 1 or 2 millimeters some buccal bone resorption, I can live with that. I can compensate that with my implant. But if it's more than that, I'll go for a delayed implant. So I never go beyond 1 or 2 millimeters from the buccal crest.
So
If
range about
margin, it will be maximum 4 millimeter, 4 to 5 millimeters from the buccal gingival margin. From the papilla, it could be calculated at 6 millimeters. That's my maximum. But keeping in mind, I use implants that allow subcrestal placement. That's really important. Okay?
thank you.
You're welcome. Okay, that's a nice picture of the buccal gap, and that's the way we shouldn't do it. We shouldn't raise the flap and see the thick buccal bone. Okay.
Yes.
Okay, what's the current knowledge that we know? What's our current knowledge? So, first of all, let's tackle the buccal plate. From a study which was published by our group, by Dr. Susie and me, we looked at several cone beams of young patients which are healthy, not suffering from periodontitis, which do not have any periapical lesions. What we found out that most of the cases have very thin bone or thin bone. So what we did, we classified the cases into buccal bone thicker than 1 millimeter, cases from 0.5 to 1 millimeter, and cases which are less than 0.5 millimeters. And we classified it like very thin, thin, and thick. We only found that most of the cases were between 0.5 and 1 millimeter. So we had like 100 cases, 64 of these cases were 0.5 to 1, or even more. Just 8 cases were thick, and just a few cases were like very thin, providing that we went 2 millimeters from the crest. When we got a little bit higher, we found just 2 cases which were very thick. So that's another advantage of going a little bit deeper or placing the implant a little bit more subcrestal. You'll end up having more buccal bone or thicker buccal bone, which allows you to get better results. Okay, same applies for the lateral incisor. So to wrap it up, when we go 2 millimeter apical to the crest, we found that 86% showed thin bony wall. That's most of the cases. And only 6% showed a thick bony wall, and 7% were very thin. So if we're gonna go according to the strict rules for Boozer and the recommendation when and how to place implants, he had a very nice paper which was published, like I think 2 years ago, 3 years ago, when and why, how to place your immediate implants. We should place only implants in 6% of the intact bony wall. So first of all, we're gonna get 100 cases. Around 20 or 30% will not be even in the considered because of the deficient or the defective buccal bone. And of these intact buccal bone, most of them will be not thick enough, and most of them will be thin enough. So we were thinking about, is there an idea or is there a way we could place an implant in these 86%? So if that can happen, it will be really nice to be able to place your immediate implant in most of the cases. Okay, what we know from the current knowledge from animal studies, from human biopsies, and from human studies and cone beam CTs, that whenever you're gonna place an implant and you're gonna extract, you're gonna lose bone. You're gonna losing bone is part of extraction, because when you extract, you're gonna lose bundle bone, which is histologically part of the periodontium rather than part of the bone. So if you're gonna extract, you're gonna lose bone. If the buccal bone is quite thin, you may end up having no bone at all. This is a very nice paper by the Chapius group or the Boozer group in Bern. Here you can see on the cases, especially on the upper left cases with the red. Here we can see that, sorry. Here you can see that the red area, we're losing bone in very thin cases and in thin cases, while on the right-hand side, with the thick cases, you don't lose any bone. And on the cone beams, here we can see that bone loss is minimal with thick cases and evident with thin cases. We should know that the bone loss that we're gonna see will be most probably in the midline and exactly where the aesthetic area is. So if you have ever seen an implant with the recession in the mid area, you should know that the implant was either placed too buccally or the dentist or the implantologist placed it in thin bone. So the idea of this paper of Boozer, he actually took 2 radiographs, 2 cone beams, one at the time of extraction, immediately after extraction, like few minutes after extraction, and the second one was 8 weeks after extraction. So what he saw that you're gonna lose lots of bone. And if you look at the green figures or the green pictures on the right, these are actually superimposed images of the pre and post, showing the unpredictable recession or bone loss happening on the buccal bone. And if you're gonna lose buccal bone, our rule as periodontists, soft tissue will follow the bone. Whenever the soft tissue and bone is lost, it's a matter of time, and soft tissue will go and disappear. Of course, I know Zucchelli has worked on this, and I know you have been discussing that issue with us and with many authors. Whether just is it enough to place thick buccal bone? I think it's, in my opinion, it will stop the recession, but I don't know if it's predictable for all cases. And how about the long-term prognosis? And at any given day, I would prefer bone than soft tissue. So if I can keep the bone, I'll keep the bone. If not, if I have only soft tissue, I'll work with what I have.
You mean to compensate for the bone resorption with the soft tissue graft?
If I have a case which was an intact implant
Yes.
and the implant was not placed too buccally, it was just in thin bone, I'll just place soft tissue. And that's a compromise. That's just an heroic attempt to save the implant. This is not the line of treatment, in my opinion. Okay, so that's again what we said before, that if we're gonna place an implant with buccal bone at least 1 millimeter, we're just gonna place implants, immediate implants in 5 to 10% of the single tooth extraction. So what happens to the rest of the 90%? It was recommended by Boozer in his paper, which is part of the guidelines also for the ITI, is to go for early implant placement. That means I'll wait for soft tissue healing, which is a few weeks, 3 to 4 weeks. Then I'll do an open flap procedure. I'll place bone. I'll place a membrane and place the implant and wait for the implant to integrate. And then I'll have my implant after like 3 months. The problem with that, whenever you're gonna open a flap, you're gonna be faced with the morbidity of any surgical procedure. You'll get more bone loss. The extra cost of placing a membrane and a bone graft is immense. It could be as great or as an implant. So you're just adding cost to your patient, unnecessary cost, in my opinion. So what we did, we looked at the thin wall phenotype with facial bone less than 1 millimeter, but larger than 0.5, which according to our classification is the thin bone. And we said, if we're gonna do that, maybe we have to look at the x-rays. We're all working with cone beams. What we found out, that actually all the cone beams has an inherent defect of underestimating the facial bone up to 1 millimeter. So from a paper by Peterson, I think in 2016 or 17, he found out in human cadavers, he was comparing cone beam CTs of these human cadavers and the clinical direct measurement, and there was some discrepancy of up to 1 millimeter. And most of the cases had a deficiency of 0.5. And cases on the cone beam which had fenestration or dehiscence were actually intact in real life. So you can't really rely 100% on your cone beam. There's also some defects. So let's speak a little bit about the jumping gap. Does anyone have questions about your buccal gap or the buccal plate?
No, we don't have questions so far.
Good. So the space between the implant periphery and the inner surface of the bone, that's called the jumping gap. It has a horizontal and vertical part. You can see in the picture, this is a nicely placed implant, totally palatally, having a nice buccal gap on the buccal surface. And this jumping gap has been open for debate for a few years, whether to graft it or not to graft it. I really don't see it as a big issue. If it's too big, bigger than 2-3 millimeters, I could graft it. If it's smaller, I do not graft it. Tarnow and his group, like Stefan Shu, they were in favor of grafting it and even putting the graft up to the soft tissue in order to give the soft tissue a little bit more strength. It was like enforcing the soft tissue with a layer of granulation tissue, which is pebbled with little pebbles of bone graft. So sometimes I do that. It gives nice results, but I mean, it's not a must. It's your own choice. I think it's open for debate. I do believe that if you place bone graft up to soft tissue, it will help, but do not place large grit bone graft. If you're gonna go for that, go for smaller grit bone graft, even the nano bone. It will give nice results. It will not go to waste. So about the buccal gap, the debate of whether to graft it or not is not a big issue. I mean, it really doesn't matter. What matters is having one. Having a buccal gap or a jumping gap is really essential. Why? Because when the future bone that will form on the buccal surface of the implant is actually now the gap. So our current gap is the future buccal bone. So when I place my implant palatally, when I use a smaller diameter implant, for instance 4.1 instead of 4.8, I'll have a larger gap. That means I'll have more buccal bone in relation to the buccal surface of the implant. So I'll end up with having better results than just having a wider implant. If I place a wider implant and placing my implant in the mid of the extraction socket, I'll end up having nil jumping gap, thus having no future buccal bone. So I'm programming failure if I place my implant in the mid of my extraction socket.
But doctor, does the buccal bone thickness has anything to do with the decision of whether to graft or not? I mean, if you have a thin buccal wall, then you go for grafting. If you have a thick wall, then you don't go for grafting.
No, I don't. I don't see its relevance because if you use our concept, it doesn't really matter.
Okay, and we have another question about the graft material. The ideal bone graft material to fill the jumping gap.
Doesn't really matter. Doesn't really matter. As long as you don't use large granules, it doesn't really matter. Use small granules. And here it will heal. It's just a gap filler. You have a 4 osseous wall defect. It will heal even if you don't place anything. Has been proven by many authors. I just place it in order not to miss a chance. But I'm sure if I don't place any, if it will heal, it would just heal.
It's a small contained defect, so you really can put anything and the clot will do the rest.
Yeah, it will. Biology will says it will heal. Histology says it will heal. It's not really that important.
Yes.
Okay. Okay. How does healing appear after extraction and bone placement? Woven bone will fill the gap, and there will be a continuity between the between the old bone and the implant, and exactly at this process, that's the whole idea. We'll start a race between building bone and bone resorption. The bone formation will start from the inner surface within the woven bone of the old bone, and the resorption will start at the bundle bone, which is part of the buccal bone. So this race is actually what will determine how the implant will heal. If you have very thin bone and you have a very thin gap, you'll end up having very thin bone or no bone at all. If you have very thick buccal bone and you'll have a big gap, like in premolars, that's why there's a nice paper by Hemmerle who recommended to place immediate implants in premolars because you have the advantage of placing your implant more palatal because of the anatomy of the socket. So when you place your implant in the palatal root, for instance, of the upper four, you'll have a huge gap, like 5-6 millimeters, and it really doesn't matter if you have a buccal bone because buccal plate, because it will heal. So actually, if you're gonna go for premolars with a huge buccolingual dimension, just place your implant palatally and it will definitely heal.
And doctor, here we have a question from Abir, our Abir. She's asking that after placing the implant the way you just mentioned, you will not have a gap at all between the implant and the palatal wall, meaning that the implant will be actually touching the palatal wall.
Yes, I'll drill part of the palatal bone. If you look at my osteotomies, part of it, the palatal wall will have a small indentation from the drills. Yes, it will be embedded within the palatal bone. Yes.
And we have another question from Azza Nasr about the jumping gap. She's asking about adding biomaterials like emdogain in the gap. Do you have any knowledge about that?
Why add emdogain? Waste of money. It will definitely it will help, but it's waste of money. Use it for recession. You'll need it there.
And more challenging defects, perhaps.
So our idea was, how about giving some advantage, or I mean, you have this resorption from the old bone, and you have some deposition of the new bone, and it's a race, and whoever wins will determine the end effect or the outcome of the implant buccal bone. So we were thinking about, we'll place the implant more palatal, more subcrestal. So what if we can use an implant system? We use the SL Active Straumann implant system, which has the advantage that it enhances early osteointegration. It decreases the healing period, especially the early healing period, and decreases that from a few months up to 3 weeks. You can fully load these implants after 3 weeks. So you have full osteointegration after 3 weeks. And the company claims you'll get better bone to implant contact. We all know that normal bone to implant contact varies for between 40% till 80%. They claim that in their case, you'll end up having 90 plus or at least 80 plus bone to implant contact area. So the idea was, if you're gonna use these implants where already bone deposition occurs within the first 4 weeks or 3 weeks, and we know that the whole resorption or the paramount amount of resorption occurs at the first 8 weeks. So if we're gonna go for that implant and already have our bone placed and deposited within the first 4 weeks, so we don't have to see the resorption at 8 weeks. So it's just like having an advantage or like a head start and in this race. I think you get the idea.
Yes.
So we use the SL Active with which exhibits rapid healing, correct 3D positioning, and we looked at the cases. We had our control, which were thick cases, which were more than 1 millimeter, really thick cases, and thin cases. We excluded very thin cases, and we excluded cases which had fenestrations or dehiscence. So we just limited our cases to 0.5 to 1, which the range was, I think, 0.6 or 0.8, and thick cases, the range was 1.2. And we're currently in the final stages of the first study, which is the cone beam study, which evaluates the early changes after 8 weeks. So after placing the implant, we took another X-ray, another cone beam, and looked at the outcome after 8 weeks. 8 weeks because we were working in reference to paper of Chapios to see whether we had this massive bone resorption they claimed could happen, and to see whether there's a difference between these cases, the thick and thin cases, after 8 weeks. The other study, which is still ongoing, we're nearly in the final stage of placing the last implants, we'll be looking at the pink aesthetic score, crestal bone resorption, buccal bone changes, and we'll be doing a final cone beam after 15 months. there's a nice paper by an author from, I think, from Denmark, Grundig. They placed the implants and used the same concept as we used. And what they discovered is placing the implant more palatally uh, led to more bone. So cases with thick bone and with thin bone, this was a retrospective study. They didn't aim to do that. They were just looking at the cases and had a look at the pre-operative and the post-operative and had a comparison between these cases and found out that if you place your implant palatally, subcrestally, you'll have more bone than you started with. So that's the first idea we had, or the first paper we read, and gave us the idea that maybe our concept may be correct. What we did with our friend Dr. Yahya, we superimposed the pre and the post-operative cone beams together, and we looked for resorption. We used the scanning device possibility, or the feature within the software. Actually, Mashali and Yahya did it. I think Yahya did that. And here we can see in red, that's the pre and the post superimposed, and you can see there's nearly no difference in bone resorption between the pre and post-operative case. But of course, this is one of the very thick cases. You can see the buccal bone, immense amount of buccal bone. So, but it was really nice to see that there is no difference between the pre and the post-operative case.
Yes.
What we found out regarding the bone resorption, that in the thin cases, we had an overall bone loss of about 0.7 millimeters. And in the thick cases, we had a bone loss of 0.6 millimeters. So actually, the bone loss was non-significant. So we didn't have any significant bone loss, which was not really expected, but could have been expected according to the literature. So first, data, buccal bone resorption and thick was not that different. Second item of data set we did, we aligned the two cone beams together, the pre and the post-operative cone beam, and measured the buccal bone after implant placement and compared thick and thin. As we can see in the picture, we just measured from the implant to the buccal bone in thick and thin cases to see how thick the bone was. We measured, I think, at 5 or 6 points, 2 millimeters apart, and this gave the advantage that we knew where the thickest bone was. What we found out that the thick buccal bone cases, they started out with 1.6 millimeters, which is very thick actually. And post-operatively, we ended up having 3 millimeters of bone. So we had lots of bone in the thick cases. So let's have a look at the thin. The thin cases were 0.6 max, and the standard deviation was 0.3. That has the thickest case was around 0.9, and the thinnest case was 0.3. And we ended up having a mean of 1.8 millimeters. So actually, we ended up having enough bone buccally. Yeah, I know it's less than the thick buccal bone found on the thick group, but we don't need that much. We only need one in all the literature. If you had 1.5 millimeters buccally, this is more than enough. And we actually ended up having 1.8 millimeters. It will be very interesting to see that buccal bone after 1 year, how it will be after loading. And we should put in mind that these cases were all done with cone beams, which underestimates the cases also by 0.5. So I think we had enough bone cases.
Even more than we had even more than that, because if the cone beam underestimates the bone, then clearly we have maybe even more than this.
What's really important is that in all cases, we didn't have mid-buccal resorption, not in the thick cases and not in the thin cases. So in not one single case, we had a buccal bone resorption. We didn't have that pattern seen on the paper from Chapios, where they had mid-buccal recession. We didn't have it. Uh, the final outcome, we measured the whole buccolingual thickness of the ridge, seeing it pre and post operatively. What we found out that the buccal bone in thin cases, we started at 8.5 millimeters and ended up with 7.9 millimeters. We just lost about 0.6 millimeters, which is not a lot. In the thick cases, we started with 10 because it's a little bit thicker, and we ended up with 9.3. So in both cases, we had some loss, which wasn't really grave, and it was not statistically significant. So from the data, what we have is it's actually on the short term. We're talking about 2 to 3 months. The cases do work. We have nice cases. We have nice buccal bone, and we have stable buccal bone. And I'm nearly sure that none of the bone we have seen will disappear. But to be sure, we're going to follow up these cases for another year or a total of 15 months to see and to confirm these data sets.
Doctor, let me clarify something. We didn't use any kind of bone graft to fill the gap in all the cases, right?
We did. In all those cases, we placed Straumann nanobone. This study was completely funded by Straumann, and so in the protocol we had to choose whether to place bone or not, and we chose to place the nanobone in all of the cases. So in all of the cases, irrespective thin, thick, whatever, big gap, small gap, we just fill the gap with bone just to remove any confounders.
Yeah, I think this is really important parameter because all gaps were filled.
Yes, all back. But do you think it made a big difference?
I think it may affect something, especially with the larger gaps or thinner bone. I think it has something to do.
Maybe next time we'll not place bone. I will see.
Okay, we have another question from Abir. She is asking about the reference points during the superimposition of the two cone beams. What were the reference points used? I think we used multiple reference points.
Yes. Okay. We did two alignments. The first alignment was a 3D alignment, which we used the feature of the scan appliance. So we used, for instance, the incisal edges of the neighboring teeth.
Yes.
Post-operatively, I think 6 or 8 points were superimposed to get the 3D alignment. The other alignment was 2D, and that was done manually by, and of course, we aligned the cases in the cone beam lab or the cone beam facility to enable to, as much as possible, to get the same X-rays. But afterwards, the cone beams were aligned manually to have the same section of the implant or the tooth where the tooth has been, and in order to have the most accurate data.
So it's basically the neighboring teeth, the incisal edges of the neighboring teeth and the neighboring teeth.
Yes. If you have a look at these cone beams, you can see clearly that all the cases, irrespective thin or thick, they ended up having bone. Some of the thin cases had more bone, some of the thick cases has less bone. So it's look at of the implant. Each of the cases, I mean, the implant is on the left and the case is on its right. So that's a pre and post.
Yes.
And if you look at all the cases have nice buccal bone. Even the lower right case where you have very thin bone, which was really a little bit challenging to do or risky to do, we ended up having really thick bone. Okay, if you go now, if you stop looking at X-rays, I love to look at the actual cases. We'll be looking in 15 months. We'll be looking at pink aesthetic score, crestal bone absorption, buccal bone changes. But now we don't have these data. I'll just be able to show you the cases that were done and how they look currently. If we look at this case, this is the first case we have done. Actually, it was upper central. It was a little bit rotated, as we see on the second picture. It was extracted achromatically. Here you can see where the implant was placed, deep and very palatal. This is a really nice picture where you can see that the gap is really apparent, and you can see there's a huge gap between the implant and the buccal bone. In all cases, we placed a healing collar, as you can see in the case, and that's the nanobone which was placed. And we didn't place a collagen plug, we didn't place a membrane, we didn't raise a flap, we just placed the bone. And the bone, as I always get a question, the bone didn't fall out because after a while there will be a clot. The clot will, due to the fibrin part of the clot, it will hold. Your clot does not fall out, and the bone will be part of your clot, so it will not fall out.
Yes.
Okay, that's the same case. If we look at it, if you look at the regular Verhauser, I think most of us are acquainted with the regular Verhauser, which looks at the mesial, distal papilla, alveolar process, and curvature, level of the gingiva, and mesial and distal papilla, of course. If we look at the picture at the middle, you'll see that the case is a really nice case. It could get a full mark in Verhauser, but we wanted to be a little more critical. So we decided to add 2 points to the Verhauser classification. The first one you can see on the left, it is to take a picture of the emergence profile and give also a point for the emergence profile. How natural does it look? So if we look at the left picture and the emergence profile of the center, I think it will get a full point, 2 out of 2. The second point that we added is the buccal concavity. How much of the buccal concavity or convexity, sorry, did you lose? 1 millimeter, more than 1 millimeter, less than 1 millimeter. In this case, we just lost a little bit. I doubt it was more than 1 millimeter. So we really had a nice outcome in this case. This was the first case we have done, and it was actually a thin bone case. Here you can see on the left side the difference between how much we lost. The total convexity we didn't lose, but at the tip of the, not the tip of the papilla, on the buccal area, exactly at the buccal area, we lost some tissue. Here you can see it, but not significant. If we look at the final crown, you'll see we didn't lose anything. It's just a little bit if we were very strict and we look at the occlusal view. So when we look at the occlusal view, I would give this case in our modified Verhauser, it will be, if we add 4 points, it would be out of 18. I would give 17 out of 18. And this is the case. And here you can see we had some bone loss, but what really happened after 12 months, we had some bone gain. After placing, I don't know how we got this gain, but we did see some gain. I think due to stability, maybe the implant surface, but we ended up having some gain at the end and just having some 1 or 2 threads showing bone resorption. Clinically, the case is beautiful. We don't have any problem with that. And that's the case in the pre and post-operative. You can see we started with a very thin bone, intact bone, but very thin. And here you can see on the left-hand side, you can see we ended up having thick bone. You can see part of the graft still present on the buccal surface, even more crestal to the old crestal bone. Maybe it will resorb with time, but it will give some fullness and some augmentation of the soft tissue. That's another case, which is one of the nice cases where the cases started with some extra soft tissue. So we decided not to remove the soft tissue because we were afraid that we could lose some of the soft tissue if we removed it beforehand. Actually, we gained even more. If you look at the right-hand picture, We even gained more soft tissue. So I think at the end we'll remove some. You have to remove some tissues. We ended up having thick tissues, and we'll just remove some tissues to have a perfect gingival margin.
The doctor, this case was thick to start with, right?
This case was no, it was thin. If you look at the case, it was 0.6, 0.8. It wasn't a thick case. So it doesn't really the idea of having thick bone with thick soft tissue, it's not the norm. You can have like thin or thinnish bone like 0.8 as in this case, and you have thick tissues. They're not related. They're not how do you call it? It's not a Catholic marriage.
Yes, but you know, this is totally against what we have in the new classification in the paper of the BESADA, of the mucogingival problems, that correlates the thick phenotype with the soft tissue and the amount of chitinized tissue and the bone.
Yeah,
So,
which is from what I've seen, and from if you look at the paper from Buder, he had the same notion, and just remarked it that he could not, and did not see any relation between thick bone and thick soft tissue. You could have thin or thinnish bone and thick soft tissue, and that's biology. You can't. I mean, it's not thick and thin. You have 0.7, you have 0.8, you have 0.9, you have 1. You have what's thin and what's thick. Is 0.9 thin and 0.99 thick, which is actually doesn't make sense.
yes, the cutoff points are not really clear, and the idea of strictly correlating the thick tissue to the thick bone is not really valid.
Doesn't make sense for me, to be honest.
Yes.
So this case where we started, and this is one of the nice cases where we had lots of bone and lots of buccal bone, and we started up with a rather thinnish case. Another case, which is an upper central, which was fractured. And if we look at the lower left picture, we can see we didn't lose any of the buccal bone or buccal convexity. One of the really nice cases. And but if you look at the emergence profile, if you're really strict, you can see it's a little bit not normal. You can see emergence profile, it's good, but I mean, if you're gonna be really strict,
yes,
it's beautiful, it's really nicely done. You have amazing pictures, but still, just to be on, we need to be very strict in order to push this concept. If we're a little bit lenient to ourselves, we'll get lots of criticism. So being really critical to your own self, so you'll get less criticism afterwards.
This is the Nahass school after 10 years of work.
This picture, we can see we didn't have any bone loss at all. And here you can see how deep the implant is. And here you can see we have buccal bone. Little buccal bone, but enough. And here you can clearly see that there's a cortex, which is buccally present and which is totally intact. It's always difficult to take cone beams when you have an implant because of the scattering.
Yes.
So even by using filters, we end up having one of these images because the bone was rather thinnish and ended up having thinnish. It ends up a little bit with scattering, but I can detect the bone very clearly and where it ends and where it starts. So this is one of the cases we started up with thin bone and we had beautiful results. Another case, also fractured central. Here we can see the fractured central, the extraction, and on the lower left, we can see how the implant was placed deep and with a huge gap. And at the lower right picture, you can see the outcome. Really, you can tell which is the natural tooth. Of course, our implant's a little bit shorter. The temporary was a little bit shorter. But if you look at the final pictures of his temporary crown, you can see you can't really tell which is which.
Yes.
And that's his final. We do 2 temporaries. One which is done by hand in the clinic, and then we do a PMMA. where the patient keeps it for about 8 to 9 months. Then we take another impression and do the final crown. So most of the cases you'll see that they have just PMMA crowns, not final crowns. It also helps us to adjust um,
Emergence profile.
crowns needed and to have the final soft tissue, perfect soft tissue, in order when we take the final impression, we'll get the crown as we need them and want them, and we do not do any changes in the final zirconium crowns. If you look at this case, if you look at the left-hand side, you can see we didn't lose. The emerge profile is really nice. You can't say which tooth is not natural. If you look at the lower picture, you can see also at the most buccal or more crestal soft tissue, you lost a little bit, but you didn't lose from the overall contour. So also one of these cases, I would give it just a -1 due to this minor defects. But you can't see it when you look at the patient in front. If you look at the page as a upper picture, you just see it if you're taking a closer view and have a really look. We didn't have any bone loss. You can look at the cases where the picture in the middle, that's a temporary crown, temporary abutment, and with the temporary crown, that's the temporary crown. And we do take pictures to make sure that the temporary crown is fully seated. Okay, that's a really interesting case with the lateral. If you look at the upper left picture, you can see that the margin of the lateral is already at the beginning at the level of your central, which the central is a little bit low, and we have it's looking a little bit square. So when we started this case, we decided that we'll end up having a gingivectomy to the central. Just replace the implant, done the extraction, and we ended up with the picture and the lower middle part. And after a while, we ended up having this picture on the right, where we got actually more soft tissue formation and thickening, which was a little bit, not expected, but it ended up having more soft tissue than expected.
It's not just coronally placed, it's also thicker. I think you can see that the margin is thicker.
Which was really weird. Yeah, I don't know why it's happened. And here's the case. You can see some bone resorption, especially on the distal, but really minute. Okay, these are one of the cases where the patient came to us with a poorly constructed PFM. It was a bridge, and the previous dentist went for filling the papilla with porcelain or pink porcelain, which I do not like pink porcelain. So it was really a challenge to remove the bridge, and we placed the PMA crowns and waited for the case to heal. Unfortunately, after a while, she broke her left lateral, and we removed the tooth, we placed an implant, and here you can see the picture on the lower right with the final crown at the day of of crown placement. There's a little bit still a defect on the mesial papilla. It's not 100% fill, but I'm sure that it will fill with time. I'm sure you'll get that because when we placed the final crown, it was a little bit less thicker or less, it was more slender in the final. I think it will fill.
Yes.
But
Because you can also see the papilla fill between the centrals and between the right central and lateral.
I think the outcome is amazing to see how we can change cases, and it's more even amazing to see how an implant will be part of this aesthetic smile without being really different, without being able to differentiate between implant and a crown. And that's the case. Here you can see just a little bit bone resorption on the distal, but on the medial you can see we got some bone formation on the tip of the crown, of the tip of the implant. And that's actually uncommon with the Straumer implants. You can see that more with Ancrus implants or Bicon implants. And here you can see this case was a really thin case. This was one of the risky, the most risky case that I have taken. And if you can see, the bone was, I think, about 0.2, but it ended up having a really thick bone, and it went beautifully, better than expected. But the patient, if you look at the biotype, would you classify that as thin biotype?
Classified as thick.
Or at least regular or medium biotype. But look at the cone beam. If you look at the cone beam, it say this patient has definitely a thin, very thin soft tissue, which is not the case. Look at the picture on the left at the day of the extraction. You can see the thick soft tissue, the stippling. It's really thick tissues. If you look at the old picture where the old PFM are present, this is not thin tissues. I can't classify it as thin tissues. Look at the X-ray. So having this idea thin, thick, thick, it's not true. You always have exceptions, or actually in this case, I think exception is the norm.
Maybe we can add this correlation thing with the final outcomes reported in this study.
Yes, we can do that.
Doctor,
Okay.
let me ask you about this previous case in the previous slide, because in the preoperative X-ray we can see that yes, this one. In the preoperative X-ray, we are not sure if we have dehiscence or fenestration or not. And with the implant placement, you can see that part of the buccal bone looks like it's interrupted or something. So clinically, was this buccal bone intact after
Yes.
extraction?
Yes. We place implants when we're totally sure. After extraction, we went with a periodontal probe. We probed the whole inner surface of your of socket, and we made sure we didn't have any defects, buccally, dehiscence, nothing. So, I don't think this defect on the left is really a defect. I think it's just from the X-rays.
Yes.
I doubt you can have such a big defect around the implants.
So it's another proof that also the cone beams may underestimate the amount of bone clinically found.
Okay, this was one of the canines. I always am afraid of placing implants in canines because the root is quite long, so I have to use really long implants. And the problem is the convexity. I mean, mimic or keeping that convexity is always difficult, because if you place your implant a little bit more palatal, as we always do, and you lose this bulge, and you'll end up having, from the occlusal view, buccal bone loss. So, but in this case, we placed the implant here. You can see the implant was placed palatally, and we placed bone graft. And if you look at the lower left picture, you can see that you have still the alveolar process convexity. You can't see if it's a crown or an implant. Of course, the color doesn't match because all of these are PMMAs. They're just temporary crowns to fill the area where we can adjust the papilla to have mesial and distal perfect papillas. Even we have here a little bit more soft tissue than needed. We'll have to adjust that and to get less convexity, less gingival margin. Here you can see we have some bone resorption in the medial, but otherwise it's okay. Because of the canine, you can see in the middle X-ray, you can think it's really near the premolar. But if you look at this X-ray, at this picture, you know it's really far away from the premolar. It's not near the premolar. And
question about the measurements of the buccal plate, since we just mentioned that the cone beam may underestimate the actual clinical buccal plate. So Ahmed Ashraf was asking about the method of measuring the thickness of the buccal plate. We still measure it from the cone beams.
Yes, that's the only method to be able to measure it, unless you do we're using a system which is we adapted from Merhib. It's a device which doesn't really measure the buccal bone thickness. It rather measures the changes that occurs.
Amount
So
of
it it quantifies the changes or the resorption or the addition of bone that happens after implant placement. I don't think we have a picture of it. We didn't include it in this lecture, but I'll gladly add it or send it to you if you want to. Here we have another case of a canine, which was really difficult because if we look at the canine, um, especially the upper left picture, we can see that the soft tissue is very thin on the area near the buccal soft tissue. So it was a risk of tearing it or while extracting a tooth. But it went fine. Here we can see you place the implant palatally, deep. We look at the healing with the healing color. We had so much soft tissue that even covered the cover screw. And when we look at the picture at the left, can see we have beautiful emergence profile. Uh, if you're a little bit critical about the picture, why we didn't have any papillas, the patient started out having no papillas because he had some sort of periodontitis. If you look at the lateral, it already had some recession at the beginning. So this case, despite having not having 100% papillas, if we look at the contralateral, which is the same amount, would give us a full mark, even we do not have the full papilla height.
we always have to compare to the baseline situation as per the latest evidence.
When we look at the X-ray, this case was rather thinnish. It wasn't a thick case, but if we look at the cone beam afterward, we ended up having massive amount of bones, like more than needed, and that bone is what's keeping the buccal convexity intact. This is a nice picture of all the cases we have nearly done. And if you look at them, you really can't differentiate between which is thick and which is thin. For instance, one of the worst cases, the lower left case, if you look at that, patient lost his crown, papilla was a little bit lost, and we had to replace it. We have some recession, not really recession, we have some papilla loss, it's filling. This was a thick case. The nicest case, if you look at the upper left case, which we presented, that's a thin case. The whole first row, that all of these are thin cases. The first and second pictures of the second row on the left, these are also thin cases. The fourth one, or the second one from the right, second line, it's a thick case. We have a little bit of recession. So it doesn't really, from our perspective, it doesn't really matter whether you have a thick or thin cases. It didn't give us more, we were not more sure when we placed in thick bone, not anymore. At the beginning, it was the case. We were a little bit skeptical when we placed in thin bone. Now, it's not the case. I do place in thin bone without any hesitation now. That's also a picture of all the cases, or most of the cases we've done. And to wrap things up, till now we have to have an intact thin buccal bone, thin meaning ranging from 0.5 to less than 1. We didn't venture to 0.2 and 0.3, except in one of those cases which I showed you, and it went beautifully. But what we can say with confidence that if it's between 0.5 to 1, it will work. Place your implant as palatal as possible. Have a gap. Bigger than 2 millimeters is even better. Just place it as palatal as possible. And if you place it palatally, don't be afraid of the prosthetic part. You'll end up having a screw-retained restoration, which is really a beautiful restoration, which will give you more flexibility. Place your implant subcrestally and use a system, in my opinion, use a system that allows placing the implant a little bit more subcrestally. It will give you a running space for your emergence profile. It will give you more freedom to play with your crown and how to form your crown. Correct 3D positioning is essential. It's of paramount importance. If you do that, you'll end up having a really nice implant. Using the SL Active implant, which helped and accelerated the healing, I think it has some benefit. I would love to try it out without the SL Active implant, trying it with regular implant. Is it about the correct positioning and the concept of bone healing, or is it about the actually accelerated healing? That would be a nice study to see. Yes. That's our team. Placed according to the how I got the pictures, not of importance. Musa, I think most of you know Nada, most of you do know her. Umneya and Susie, and our youngest Masheli. They all helped a lot in this study and other studies. We're working as a team. I think we're one of the few teams working now in Egypt and actually producing nice papers. We were able to have international relations. We're working with Straumann. We have good relations with them. They're pushing us. They're giving us more funds. We have another fund. We have actually 2 more funds from them. Nada's working with a fund from Straumann Group halfway through. صح?
Hopefully. We just need to get back to work.
And we have another study lined up. We have already the approval. So I'm really proud of them, and wouldn't have reached what we have reached if we wouldn't have been working together. Thank you.
Thank you so much, Doctor. I'm really honored to be part of your team and part of all this beautiful work. And I thank you so much for the detailed discussion of each single case. This was really precious to listen to and to understand. So I thank you so much for that. I have just one question about the parameter that you added to the pink aesthetic score that we already know, the emergence profile parameter. I need you to explain in details what do you mean by emergence profile? What
Okay.
exactly are you measuring in this parameter?
Okay, if you look at the what's a nice emergence profile actually? When you see the crown mimic or adapting to the
Contralateral tooth.
going from underneath the gums, going out with a certain angle, not too obtuse, and looking like the natural tooth. So we have like 2 or 3 points, or when you look at it, you look at 2 or 3 points. First of all, what's the angle of the crown coming out underneath the gingiva? How obtuse it is.
Okay.
Flat or too flat, you can correct it. But if you have to do a really 90-degree angle to reach the level of the neighboring teeth, that means that you have some buccal resorption. So the flatter the angle, the better the outcome. So we're looking at the angle at which the soft tissue, the crown is emerging from underneath the soft tissue. How the soft tissue looks, is it rolled, thick, nice, or is it just flat and flabby and you know how it looks when you get really thin tissues? The third point is looking at the neighboring tooth and how it compared to these. When you look at these points, you can give a score.
But I mean, we already have the shape of the gingival margin in the old score. So I was asking about the exact differences of adding this parameter.
Gingival margin, you're looking at just at like this.
Yes.
We're not looking at this. We're looking on the side. That's it. That's your gingiva, and that's your crown. This area from the side. If you got a crown like this, sometimes you see crowns like that, right? That's a very poor emergence profile. That means you lost all the soft tissue here and all your bone, and you have to compensate with vertical or for horizontal porcelain to adjust your crown to be in the correct buccolingual position. I don't need that. I need my soft tissue to be buccal, that my crown comes out naturally. That's what I'm looking at. I'm looking exactly at the area of junction between the crown and the soft tissue from the side, not from a buccal view.
So more or less, we're looking at the mesiodistal. We are looking from the mesial or distal.
Yes, we're looking.
Not
Yes, we're looking not to have over contoured crowns. And we have over contoured crowns if I have loss of soft tissue or loss of bone, basically.
Yes. We have a question from my dear colleague, Sharif Samir. He's in the prosthetic department in MSA. He's asking about the jumping gap. I think you said this in the beginning, but maybe we missed it. He's asking about the jumping gap and what's the maximum gap allowed without grafting.
Okay, according to the literature, we have this paper or this histological study by Tarnow. He had a jumping gap of 4 millimeters and he didn't place anything and it healed. I'm not that brave. If it's more than 3 millimeter, I do graft it.
But in our work, we grafted all the gaps to standardize and avoid confounders.
Single one of them because it's a study and we have to just all the cases should get the same treatment.
Okay, I think that's it. We don't have further questions. Thank you so much, Doctor, for your time, and I'm really happy and honored to have you in the Education Club.
It was my pleasure.
Thank you, Doctor. And the lecture is going to be recorded and uploaded for those who missed it. So we're going to have it on demand so that they can see it.
Okay, thank you
So much, Doctor. Have a nice evening.
Yeah, same to you. Yeah, bye-bye.